Hello? Anybody here? Okay, here we go. Cranial nerves, olfactory, optical, ocular, motor, trochlear, trigeminal, decumbens, facial, vestibular, gastro, vagus, hypoglossal, on old olympus, towering top, what is it? It's, I can't remember that acronym. But anyway, everybody knows what these do. Uphill. Yep, Tony knows them all. Okay, Tony. On old olympus, towering top, they germinate thin, breed some hops. Nope, that's not it. It's been years since I even thought about that. Oh, okay. We hear you. All right. Right. A thin and a germin viewed some hops. There you go. Thank you, Jessica. Thank you. Hadn't thought about that forever. Vestibular cochlear replaced auditory or others for the A. That's right. But it's still the vestibular cochlear. That's the proper name. That's it. Okay. Or something, right. That's it. Okay, so let's move on. I think we already talked about these genetic markers. We're almost done with this section here. These are investigative biological genetic markers, so they're not proven, so I doubt that you'll get any questions about that type of a thing. And we talked a little bit about that, we didn't really get into it too much. CT and MRI, cost differential is huge. The big advantage with the CT is that it's much easier to give rapidly when you're in an emergency room situation, and it's going to give you information about potential bleeding, internal bleeding within the brain. But if you want more fine-tuned pathology, if you're looking at atrophy or some other type of disorder, you're probably going to want an MRI. And these are weighted imageries, and it's not really a big thing to get into that. We talked about it before in class. Just tells you the difference, what they're likely to look like, whether they're low, dark, or bright, or high. Let's see. MRI axial cuts bipolar patient versus a matched control. So here's your bipolar, here's your matched control. This is a CT and an MRI. You can tell this is the MRI because there are much more details here. So with non-contrast CTs, you're evaluating a new onset of an acute neurological disorder like an acute stroke, subarachnoid hemorrhage, or trauma of some type in mass with edema, hydrocephalus, mass effect, and evaluation of ventricular size. CT also gives you bone pathology, whether there's a fracture. It's easier to see than with an MRI. And SPEC has limited structural anatomic visualization. It's a radiation exposure. There's its disadvantage. It's less expensive than a PET. You can see the difference is 1,500 versus 4,000. These are probably not even accurate figures now. And then there's this functional MRIs, which are used for different reasons, and they're more investigational than used within the context of clinical issues. And it gives you some just basic background related to that. You're not going to get a whole lot of that kind of testing. And this is picking up on some atrophy here. Let me run. I'm pressing the wrong thing. I think my pointer is working when it's not. Here we go. You see around these white areas is atrophy. And here, this is a PET of an Alzheimer's patient. Should be the same person. It's a little less lit up here in the parietal areas. You can see it more clearly here and over here. And you should see some of it in the frontal region as well. It's more difficult to see. It's parietal, largely parietal temporal. This is a brain injury, and it's pointing to the spot where the injury is. And this is an MRI image right over here, same area. So you can see there's a slight degree of pathology right there. Just let me see if I can get a better pointer. Yeah, let's try that. Right there. And then over here, you see it there. But these are some of the basic findings that they've seen with schizophrenia. So you get this ventricular enlargement. You'll see that a lot. And the majority of studies report some frontal lobe abnormalities, which is expected. Subcortical abnormalities involving the cavum septum and the pellucidum and the basal ganglia, corpus callosum, and thalamus. And then you have ventricular enlargement and decreased gray matter volumes in first episodes of schizophrenic patients. So that's been known for quite some time. And in fact, the Hinckley case was contingent upon this ventricular enlargement as a means of showing the physical basis of his pathology. Functional imaging studies, we'll see positron, emission PETs, tomography, shows a relative hypometabolism in the prefrontal cortex, metabolic abnormalities of limbic areas, the temporal lobe and the anterior cingulate. And then there's some decreased magnetic resonance spectroscopy. What you'll see is decreased NAA levels in the frontal, temporal, thalamic regions. None of this stuff you're really going to have to deal with, so I'm just putting it out there just so that you'd have it if you ever wanted to look at it with any great detail. Mood disorders, same type of thing, some different findings. Functional imaging studies, depression, hypometabolism in the limbic region, and dorsolateral frontal cortex. Kind of what you would expect based on the functional activities of those areas. And anxiety disorders, you have the OCD, unclear findings, no volume differences in the striatal or ventricular regions, but we see hypermetabolism with the functional imaging in the orbital frontal cortex and the anterior cingulum. Okay, we're almost done with this stuff. You need to know what the DEA does, okay? They're the ones that give you basically your substance, your DEA number, and you need to know the classifications of schedules for the DEA. You need to know what the Food and Drug Administration does in terms of the regulation of drugs, new drugs, drug studies, drug manufacturing, etc. Okay. A little bit about study designs. Know these things like parallel groups, balanced placebo design, crossover studies, three-arm studies, uncontrolled, systematic case control, omnibus, and meta-analysis. Sort of strengths and limitations of each of those, because they could come up. And then measures of disease frequency is often referred to as prevalence, incidence, period prevalence, and then life prevalence. There's also these descriptive studies called correlational case reports, cross-sectional. Most of you probably already have this stuff down better than I do. And then the cohort studies, the prospective, retrospective, and relative risk, and case-controlled studies. Odds ratio is often used with that. This is the effect size. Essentially, effect size is roughly equivalent to a standard deviation unit, and it usually ranges from 0 to 1 or higher. And an effect size of 0 would mean that there were no significant differences, and an effect size of 1 would mean that the treated, or in this case, medicated, group was approximately 1 standard deviation better than the untreated group. So that's an effect size of 1. Effect sizes are then averaged across multiple studies to obtain an overall ES, indicating the total effectiveness of the treatment medication across an entire set of studies. There's also number needed to treat. That's becoming more commonly spoken when people are talking about the efficacy of drugs. And this is the number needed to harm. So in effect, there's actually a calculator you could get for this. You can enter the information, and it's online. It's for free. If you look for it, if you just type in number needed to treat, and you can find the little calculator. And basically what it's saying is that in order for the medication to have an effect, we would want to know how it would benefit if we treated how many people would it take to get one person to show clear evidence of improvement. So if a high number needed to treat would be bad, that would mean I would have to treat 20 people to get one patient to respond favorably. A good idea, or at least a good number to treat, would be one person. Every time I gave it to them, they were 100% go. Okay, so there's very rare that we're going to see something like that. More commonly, it's going to be in the range of 5 to 10 to find out how good that drug is. So if it takes me 10 people to get to the point where I can get one effective person responding, that's a lot. So preference would be, I really would prefer somewhere around no more than 3 or 4, but that's not the way it always works. Number to harm is just the opposite. Okay, you want a small number, right? Or no, just the other way around, excuse me. The number needed to harm. So it's just the opposite in the sense that you're trying to say how many patients would I treat before this bad thing would happen. So kind of a thing like that. So you want that number to be very high. That's what I mean by opposite to the needed to treat. You want the number to be much higher. So it'd be nice if it was 1,000 people you had to treat before you would see a granulocytosis with a particular drug. And you can calculate those things based on the research that you know. If you can look at a treatment efficacy, and then you can take this little calculator and calculate what's the need to treat. And that's when we talk about need to harm, we don't mean typically there's minor side effects. It's more the other things, the more serious ones. So this isn't spoken as much except in cases where there's something really bad. But here, this is, if you're following any of the psychiatric literature these days, you'll see this come up all the time now. Have many of you been seeing that if you're reading any of this about efficacy? Okay. No, you don't. They'd be more likely to ask you a conceptual question about that. That reflected something that you understood about it. Not really, thanks. Long intention to treat, calculating efficacy. Efficacy, right. Seeing lots of OR. What do you mean OR? Odds risk? Okay, odds ratio, yeah. You're seeing those. Okay. I listen to a lot of psychiatric presentations, and they're often using them. I'm hearing them saying that more commonly when they're reviewing the history of a particular medication and how well it's worked or not, this sort of number to treat. I started hearing it, I guess, a couple years ago, and so it's continuing to happen where I am. Let me go backwards. Anyway, so I just threw it out there. I don't even know if they're going to do it. I would be surprised if they didn't say something about that nowadays. Okay, this is, you have to know this, all right? Obviously, Schedule 1, they really don't have any practical medical use. They can be used for experimental purposes, but you have to get a license to do so. Schedule 2, high potent, okay, you can write a prescription for no more than 30-day supply and no refills. That turns out not to be true. I do it all the time. You can do, with some of the mail orders, you can order 90 days of, say, Vyvanse all at once. We typically don't want to do it because if the patient loses the medicine, it's an issue for us, because then we have a lot of medicine that's gone suddenly. So in practice, what we typically do is we write 3 prescriptions, and we put a release date on the second and the third prescription, each prescription being filled for 30 days. So this isn't exactly accurate, but you can't write refills. That for Schedule 2, you can't say 30. Take one of these each morning. This is Vyvanse. Let's say it's Vyvanse, 30 milligrams, and you're saying take one each morning with a meal or a non-meal or whatever. And you order a number of 30. You can't put a refill for that. You simply just have to write a similar prescription, but then you put a release date on the prescription. That works. But mail order, you can actually get 90. You can get 90 days. And I've even seen some local pharmacists give them 90 days. But I don't typically like to do that for the obvious reason that if they lose it, that's a lot of lost medicine. So, Schedule 3 is less abuse potential. So it's in between 2 and 4. You can write up to 5 refills within 6 months. So steroids, cyclobarbital, phenobarbital, low-grade codeine, or hydrocodone drugs. Usually these have something mixed with it to make it a lower level, like adding some acetaminophen or something like that. You have some Schedule 4s, less abuse potential. So you're talking about benzodiazepines, Darvon, Librium, Cellular, Meridia, phenobarbital, chlorohydrate, that type of stuff. And then there's a Schedule 5, which everybody forgets about. It's less abuse potential than 4, stimulant and codeine drugs used for cough syrup. Usually the pharmacist would dispense this to you directly. You wouldn't probably be able to pull it off the shelf. Let's see. So those 2 things. There's something else over here. The legal things you need to think about: informed consent, especially for minors. But every state is a little bit different, so you have to think in more general terms. The ethical issues tend to be pretty by the book, so to speak, if you would. And when you read the ethical questions, don't overread them. Take everything on face value. It's real important that you do that. Just as if you were a first-year graduate student, and the rules are the rules, you want to be able to do that. Okay. Isn't Cellular off the market due to kidney problems? Yes, I believe it is. I haven't heard of it for a long, long time. All right, competency, treatment refusal, civil commitments, patient compliance issues, and then of course malpractice. They're not going to probably ask you about malpractice. This is a culture and ethnicity. These are the sort of cultural bound syndromes that can occur, and I wrote them all out. They're in your book. They describe them in great deal. Are the ethical issues from a psychiatric association? No, it's APA, our APA, they set it up. They actually don't talk a lot. Well, you'll see that when we go back to the content stuff. The ethical stuff isn't as important right now as this stuff. They're giving this much more value, the cultural bound syndromes and the physiological differences between different ethnicities and treatment. Okay, and you can read all of these disorders. I doubt that you're going to see more than one of these, if you see any, but there may be some in there that might be worth knowing about. And then moving on, we're almost done with this stuff. Oops, excuse me. And then these are the sort of, you have these got a microphone on, please. Is it off? Thanks. Nope. It's on. Please turn it off. Hello? Okay, we're good. Non-biological issues that affect psychopharmacology is culturally shaped beliefs, what you believe about the medication, the use of the traditional and our alternative methods, and family interactions. And all of this is in your book. And then they go through each of the groups and how they are affected by various agents and the differences between the 2D6, 2C9, and 2C19 that have ethnic variations among races. And the races they're typically talking about are Asians, Caucasians, Hispanics, African Americans generally, those groups. You mean the Mass General? Yes. Yep. It's probably also in Jenikak's book in there too as well, but not as much as this. This is a clear, large chapter on it, so you should read that chapter. And it's one I listed in the book. Okay. All right. So we need to go. We need to go back to what we were doing yesterday, and we'll probably not answer all the questions. We'll go through a couple of them, but I want you to get all of the categories so you know what the categories are. They'll begin to make a little bit more sense when you look at these categories now, as we've talked about all of this information now. Okay, a few back. Yeah, there are a couple in there as well. I have a little trouble with Jews being considered a race. Okay. And historically, Hitler was the one that defined a religion as a race. It's an interesting quagmire for me. Clonazepam induced agranulocytosis as a risk for, these particular Jewish individuals. Okay. I think I'd heard that before. So that might be there. I have to go back and look on that. I agree there is some genetic questions on the PEP about us. Yep. Okay. Now, where we left off yesterday, I think, was this. So this is that first section that we started talking about. And this is a subcategory of that first section. I don't think we did any other ones. Let me see if we probably can't go back that far. No, we can't. It's all right. We'll just start there. Okay. And so I don't want to have to go through all of these. I'm just going to kind of make sure you understand the content, the timing, and sequencing of interventions to achieve maximum treatment and effectiveness, including importance of patient instruction. Which of the following statements is true? And you know where the answer is. It's C. Okay. We'll do some of those that seem interesting. I don't think my picture interferes with you seeing anything, does it? When I do that, does it block the answer? Be nice if it did. Yeah, I didn't think so. I was hoping. Okay. And this is the same type. This is a different category, practitioner-patient relationship, including its impact on patient education, medication adherence, efficacy, adverse effects, and response to side effects, and implications for the relationship when psychosocial and pharmacological interventions are utilized. So this is practitioner-patient relationship. Is an active ingredient, of course, is more important in psychotherapy than pharmacotherapy? No. Depends solely on the practitioner? No. Should not influence clinical decision. That's completely wrong. Okay. If we move you to the corner, it does. How do you mean? Like this? When I move over like this? Does that block it? No, we have to do it. Oh, you guys have to do it. Okay, I see. All right. But this is that first category. This is, the very first set of question areas, okay? That was 4. Here's a new one. This is 5. The development and implementation of a coherent and organized treatment plan of both psychosocial and pharmacological intervention with attention to comorbidities as well as evidence-based developments in psychotherapy. And this is the dodo bird effect. And it's all of the above. Refers to the observation that all credible psychotherapies result in significant therapeutic improvement, has been applied to antidepressant medications, argues against medication-specific algorithms. That's in the chapter from the Muse book. It's in there, that dodo bird effect. The case and medication management issues and strategies to enhance adherence to effectiveness of the treatment plan, for example, communication skills, patient education techniques, and cultural competence. An Asian patient believes that his penis has retracted into his body and that this condition will kill him. Before prescribing, you decide the best diagnosis is Koro. Everyone knew that, right? But that's the kind of question that's coming from the psychiatry book, okay? If you go back and the dodo, here, you want an actual definition of the dodo bird effect? I can look it up. I'll come back. Let me come back to that, and I'll read it to you. So let's keep going with this, and then when we take a break, I'll pull it out so I can read it to you, the exact same, correct response. So we'll go on. So this is a new area. No, this is a new area. Pharmacoeconomics and treatment planning, managed care, utilization review, and formulary restrictions. So the economics of a given medication, has no place in decision, should make no difference, make condition therapeutic outcome, and requires the use of lowest cost generic. It's going to affect, it may be a condition therapeutic outcome. That's the answer. So, did I get them all? So that's 8. No, I skipped one. Excuse me. I'm having a hard time. Okay, and this one is herbal and natural products, dietary supplements. So that's in there too. There's one of those chapters on all that. So you have to, which of the following herbal medications is likely to have an anticholinergic properties that may interact with TCAs and low potency neuroleptics? And the answer is B. So you're supposed to know that. Okay, this is neuroscience. This is the section, so this is area 2, and it refers to the anatomy, physiology, and biochemistry of the nervous system. This one's pretty easy. So we're talking about cellular and molecular. So the part, this is 20201, which is categories 2 and subset 1. Cellular and molecular nervous system biology, biochemistry, and regulatory processes, for example, neurotransmitters and neuromodulators systems, transcription, translation, and genetic variability, neurotropic factors, okay? And it says eukaryotes, how do you say that? I can't say it. These are just cells. Cells, I can't even pronounce that. Can anybody pronounce it? Eukaryotes? Sounds good to me. Eukaryotes. That's all right. Okay. Are characterized by which of the following? Organelle, cytoplasm, caveolus, I guess, and A and B, and all of the above. It says all of the above. These are just components of the cell. And I don't recall what that is. Does anybody know what that is? No, I haven't seen it either. I'm not sure what that is. I think that's a plasma. You're saying, Jessica, that's plasma membrane? Okay. Thanks. You're the only one that knew. Okay, number 2. We've already done this. Here's autoreceptors. This is that same part we just mentioned. So what do? They tend to downregulate receptors when activated. They inhibit neurotransmitter synthesis, are generally located on presynaptic membranes. That is true. All. This is part 2, structure function of the central peripheral nervous system. So it's which monoamine neurotransmitter is essential to the activity of gastrointestinal tract. Should be serotonin. We know that most serotonin is actually in the gut. This is the third, excuse me. Yeah, here's Bell's palsy. What are they asking, Bell's palsy? Affects cranial nerve 7. That's the facial nerve. Affects the trigeminal nerve. That's a sensory nerve. Is a result of herpes simplex virus. And then you have these choices, A and C. So we know it's not this nerve. That's a sensory nerve. This is a motor nerve, the facial nerve. Okay, so it ends up being D. Okay, whoops. Yeah, got it. Why does that happen? Click it once. There we go. And then we have the major dopaminergic pathways in the brain. This section is the major neuronal pathways and their functions. And these are, they want you to list them all, or they want you to know the nuclear group, that type of thing. So you have the tuberoal infundibular pathway, the raphe nuclei, the locus ceruleus, the basal nucleus of Maynard are all of the above. What would you say? Okay, this is norepinephrine, right? This one here. This one's acetylcholine. This is serotonin. So all we got left is this. So that would be the answer. The major neuronal pathways and their functions is the same kind of a question. So major pathways involved with OCD are what? The cortical striatal thalamic circuitry. And this is the nigrostriatum, forms an integral part of the dopaminergic pathway. Okay? And we have this major neuronal pathways and their functions, including second messengers. Again, so here's the transducer in the second messenger system is what? And the answer is what? Anybody got an answer yet? It's the G protein, right? Okay. So this is cyclic AMP, right? GTP. The ligand doesn't mean anything other than the fact that it binds to a receptor. Okay. Oops. Knowledge of the vascular supply of the brain and the blood-brain and placental barriers. The blood-brain barrier is made up of which one? Epithelial, basal, endothelial, or platelets. It's C, endothelial cells. That's right, everybody's getting that. Oops. The vascular supply of the brain and the blood-brain and placental barriers. Another question is the blood-cerebrospinal fluid barrier is located in the choroid plexus. Everybody knows what the dorsal horn is, right? The spinal cord. What's that associated with? Input usually with sensory, right? That's right. So it clicks two at a time. Okay. And then the vascular supply of the brain and continuation, something helps form the placental barrier, and the answer is B, villi. So we'll skip this because these are just some questions that weren't in the right spot, so I'm going to just kind of go through those because I really want you to see all of the content areas. It's more important to me right now. Still in 2, so you got a knowledge of the major transmitters and the neuromodulators, synthesis, storage, release, and distribution throughout the brain, and the body and the rest of the body action up to reuptake and degradation. So the neurotransmitter used in postganglionic fibers of parasympathetic nervous system is, everybody should know that, C. Parasympathetic. Noradrenergic norepinephrine would be wrong. It's acetylcholine. Okay, neurotransmitter transporters are proteins that span the cellular membrane, are part of the active transport system, are involved in the reuptake of norepinephrine, serotonin, and dopamine. It's all of the above. Correct. Oops, sorry. High tissue binding is associated with high volume of distribution. That's kind of an irrelevant question right now. Percentage of, yeah, these are wrong. They don't need to be there. You have to move those. Okay, monoamine oxidase is located primarily where? It says in the mitochondria. Which of the following drugs would cross the membranes with most difficulty? Ionized, always ionized. Oh, we'll skip that. That's a different issue. You can look at these later. Neuromodulators do not use catecholamines as transmitters, emit only hormones as transmitters, secrete transmitters that diffuse through large areas of the nervous system, having an effect on multiple neurons. You can guess just by the length of that stem that that's the answer. Hormones? Yeah, they're modulators, though, are sticking within the system. A hormone is typically classified as something that's released in one area of the body and travels to distant areas of the body. It can be going to neighbors, but for the most part, it's distant. So you're talking within the nervous system itself, like in the brain. So it's saying a distance. This is traveling and influencing other areas within the nervous system, and that's a very small region to begin with. Neuropeptides do all of the following except act at metabotropic or G protein coupled receptors. We know that's true. Act only within the central nervous system. Is that true? Nope. Right. It's false. Effect changes in gene expression. That's true. Have longer action than monoamine transmitters. That's true. Are secreted alongside of monoamine transmitters. That's absolutely true. Okay. So it was B. Excuse me. Enkephalins is found primarily in the central nervous system and in the gastrointestinal tract. Is a G protein ligand. It binds to opiate receptors. B and C are correct, and then all of the above. Turns out it's all of the above. Substance P binds to neurokinin-1 receptors, opiate U receptors, alpha-adrenergic receptors, adenosine receptors. It's the neurokinin-1 receptors. Yep. Which of the following are potential neurotoxins? Glutamate, substance P, adenosine, substance P, glutamate, adenosine, and glutamate, substance P, and adenosine. It's A, glutamate, and substance P. Okay. Catecholamines are largely synthesized by chromaffin cells in the adrenal medulla, in the postganglionic fibers of the sympathetic nervous system. None of the above. All of the above. Well, that's a bad question. Because if you say all of the above, then none of the above is involved as well. Should be E, though, but crossing out D. Yeah, that's exactly right. Silly way of doing it. All of the above should be correct. See if there's anything else in this area. Endocrine system and interface various hormones and other neurotransmitters. So feedback is best described as negative when a hormone's effect makes its gland stop secreting. Negative when a hormone's effect causes an organ to malfunction. Well, that's not going to be true. Positive when a hormone's effect is beneficial for recipient organ, or positive when the hormone's effect downregulates further hormonal action. It's negative when a hormone's effect makes its gland stop secreting. Angiotensin 2 is a catecholamine, stimulates, so this is endocrine system again, stimulates production of aldosterone in the adrenal cortex, helps lower blood pressure, promotes blood vessel dilation, is formed by the action of renin and angiotensin. So the answer is stimulates production of aldosterone in the adrenal cortex. Angiotensin 2 does that. All right, we have knowledge of the same kind of thing. Cortisol is produced in the adrenal medulla, is a mineralocorticoid, enhances insulin, decreasing glucogenesis and preventing breakdown of lipids and proteins. None of the above and all of the above. This is one of those silly ones again, but it's none of the above.